like to extend a warm welcome to you. Professor Sabatine is a professor of medicine at Harvard Medical School and a chair of cardiovascular medicine at Brigham's and Women's Hospital. He is going to talk to us today about the limits of lipid lowering and the outcomes looking from statins to PCSK9 inhibitors. So thank you very much.
Great. Well, thank you very much. It's really an absolute privilege to be part of this conference. I wish I could be there in person, but between the American College of Cardiology and then about to start service in the coronary care unit, the logistics turned out to be impossible. But I'm thrilled that I can join you remotely. And so over the next 20 minutes or so, because I really do look forward to a robust question and answer session, I'd like to address this topic, in terms of really how low we should go for LDL cholesterol. And I think the answer is we should be going much lower than we currently are. And I hope to convince you of that as I share the key bits of data. So here are my disclosures. So if we think about the relationship between LDL cholesterol and cardiovascular disease, there's a variety of different data sources we can use to try to inform us in terms of what the optimal level is and should we treat individuals with certain LDL cholesterol levels. And here's data from the UK Biobank. And this is looking at the relationship between what an individual's LDL cholesterol is and what their risk is for a composite of cardiovascular disease. The units here are in milligrams per deciliter, so obviously you can divide by approximately 40 to give you a sense for the millimoles per liter. And, the UK Biobank has been an absolutely tremendous resource. And so in looking at this, you can see a monotonic, fairly linear relationship that the lower the LDL cholesterol, the lower risk for events. And here it's sort of centered at the mean, where the value here is, just a little bit sort of under 4 millimoles per liter. And certainly in looking at this graph, there's enough data throughout that middle range that one could confidently say, yes, having an LDL cholesterol of 150 is better than 200, and 100 is better than 150. But it gets harder as we go to the left-hand side of the graph, simply because the data are far more sparse. We don't have in typical industrialized societies, sadly, we don't have many individuals on the left-hand side of the graph. And so you can see that the confidence intervals there start to expand out. And so it's harder to know the exact shape of that relationship. We were able to do a similar analysis, but now in the Fourier trial. This was a large trial of 27,000 patients with atherosclerotic cardiovascular disease and randomized to evolocumab or placebo. And overall in the trial, evolocumab reduced the risk of major adverse cardiovascular events. But what we also did in this trial was use it like a cohort, like a UK Biobank, like a Framingham Heart Study that we have here in the United States, and look at the observed association between an individual's LDL cholesterol and their risk for, in this case, CV death, MI, or stroke. And these, again, like UK Biobank, are observational data. One needs to adjust for differences in individuals who have different levels of LDL cholesterol. And here we picked 4 weeks because obviously when they went in the trial, those who went to the evolocumab arm now had a new baseline because they had their cholesterol lowered quite substantially with the PCSK9 inhibitor. But the take-home message here is, again, you see a monotonic, again, nearly linear relationship between LDL cholesterol and the adjusted probability of CV death, MI, or stroke. But now, because of the intense LDL lowering that we were able to achieve with the PCSK9 inhibitor, we had the luxury of exploring this relationship down to very low levels of LDL cholesterol. And so you can see that that relationship holds true as one goes below 2 millimoles, 1.5, 1 down to half a millimole per liter. Again, a very clear monotonic relationship. So, that's nice. And then the other question that comes up is, what about safety? And again, statins and ezetimibe and PCSK9 inhibitors are quite safe. But when we prescribe them to our patients, if they achieve very low LDL cholesterol levels, which I think are a good thing if they do, but then some individuals or some practitioners may be concerned saying, their LDL is really super low. Is that safe? And so we also wanted to address that in Fourier. And here we have patients binned across this sort of rainbow pattern here. In the purple is LDL cholesterol levels under 20 milligrams per deciliter, under about half a millimole per liter, all the way up to the red that are those individuals who are at or above 100 milligrams per deciliter, or about 2.4 millimoles per liter. And so you can see here that the relationship, there is no relationship between achieved LDL and any of these safety outcomes. Serious adverse events linked to discontinuation, diabetes, cancer, cataracts, neurocognitive, LFTs, CK, that doesn't make a difference for any of them, right? Absolutely flat across all of that. So that's reassuring. So, but those are all observational data. And I think, another complementary route would be, yes, but what's the benefit of lowering LDL in a particular individual? I'd like to know that if I start a statin or ezetimibe or a PCSK9 inhibitor in someone whose LDL is at the lower end, are they also going to benefit? And so for that, you then need randomized controlled trial data. And we do have that. And so these are data from the Cholesterol Treatment Trials Collaboration. This was from the 2010 publication, where they subset patients on the basis of what their baseline LDL cholesterol was. And you can see the binning on the far left, going from under 2 millimoles when they came in to whatever study they were enrolled into, up to people whose entry level was 3.5 or higher. And you can see in the graph that the rate ratio was essentially identical for all of these. It lines up incredibly well. Again, the same 20 to 22% risk reduction per millimole per liter reduction in LDL cholesterol, even if you're starting under 2 millimoles per liter. Now, of course, the benefit is proportional to the absolute decrease in LDL cholesterol. If you're starting lower and you have the same percent reduction in LDL cholesterol, the absolute reduction will be less. But biologically, per unit reduction in LDL cholesterol, the benefit's entirely consistent. We did the same thing in the Improve It trial with ezetimibe, and same notion. If you look on the far left, you can see the starting LDL cholesterol levels here in milligrams per deciliter, even for those starting under 1.8 millimoles per liter. So roughly 1.25 to 1.8 millimoles per liter. Then if you look at the far right, the hazard ratio per millimole per liter difference in achieved LDL cholesterol is again all the same. It's all that roughly 20% risk reduction there. So now also true not only for statins, but now for a non-statin for ezetimibe. And we did the same thing in Fourier, where we had a subset of patients who came in the trial with an LDL cholesterol under 70 milligrams per deciliter, under 1.8 millimoles per liter, and they benefited just as much. Those are the filled green squares on this graph versus the open ones. The top panel is the quintuple primary endpoint. The bottom panel is the triple endpoint, the key secondary endpoint. Again, in both cases, those coming in with lower LDL cholesterol levels benefited just as much. And so this here graph just sort of summarizes here the benefit in terms of reduction in major vascular events, whether it's with statins, ezetimibe, PCSK9 inhibitor, or a CETP inhibitor and ezetimibe that we studied in conjunction with Oxford. The benefit just lines up beautifully here. All of it roughly a 20 to 22% risk reduction per millimole per liter reduction LDL cholesterol. So certainly these data suggest that even when someone's under 70, they certainly benefit. You can take these data a bit further, and I'm going back now. I showed you this subgroup from Fourier, the 2,000 patients who came in the trial with an LDL cholesterol under 70 milligrams per deciliter, or under 1.8 millimoles per liter. And the particularly useful bit for Fourier is that because the LDL cholesterol lowering was so dramatic with evolocumab, here a 66% reduction in LDL cholesterol, we were able to drop individuals down to a median of 0.5 millimole per liter. And that gives us sort of additional insight into the relationship between LDL cholesterol and clinical benefit. And I show that here, and this will be a two-part graph. Let me orient you first to the top part here. So here is a graph where we are modeling based on someone's baseline LDL cholesterol, that's the x-axis, when they entered the Fourier trial, what was their achieved LDL cholesterol, and that's what we're plotting on the y-axis. The blue line is the placebo, and as you would expect, their baseline and their achieved are essentially the same. If you look at the red line, that's what you see with evolocumab. And so not surprisingly, then they are dropped down with that roughly 60% reduction in LDL cholesterol. But what we've illustrated here is then that shaded area in between, which starts to give you insight into what of the LDL difference between those individuals, how much of it was due to LDL being under 40 milligrams per deciliter, under a millimole per liter. So for individuals who came in the trial whose LDL was 92 milligrams per deciliter above, the achieved level is all above 40. So while we show the clinical benefit in that group, that doesn't speak to lowering the LDL cholesterol, for example, below a millimole per liter, because the achieved levels are all higher than that. But as we start to move to the left-hand side of this graph, then more and more of the difference between the arms is due to LDL cholesterol being under 40, such that at the far left-hand side, 38% of the difference of the achieved LDL between placebo and evolocumab was due to LDL under 40 milligrams per deciliter. And so then you could ask yourself, well, what's the benefit for lowering? And if there was no benefit to lowering LDL cholesterol under a millimole per liter, under 40 milligrams per deciliter, if that was the case, then if we looked at the clinical benefit in Fourier, as we move from right to left, it should become attenuate, it should become less and less, because the LDL reduction that you're achieving is more and more of it is due to getting LDL below 40. If there's no clinical benefit to doing that, then there won't be as much of a difference in event rates between the arms. But in fact, what we saw was this. Here now we're plotting the hazard ratio for MACE. And so lower numbers are better. If anything, the benefit actually grows. There's absolutely no attenuation in the treatment benefit. So these data, I think, speak powerfully to the fact that there is benefit for lowering LDL cholesterol, even when we get it below 40 milligrams per deciliter. There continues to be benefit for our patients. And so on this next slide, this is now not clinical data in terms of outcomes. This is imaging data. But in my mind, this really tells me, or I think tells all of us, what we need to know in terms of treating atherosclerosis. So let me orient you to this graph. This was from the Glagoff trial. This was an imaging trial of evolocumab versus placebo in patients on a statin who had atherosclerosis. And the imaging was through intravascular ultrasound, so putting a catheter down a coronary artery, imaging the vessel wall with ultrasound, seeing how much plaque there was, quantifying that, sort of doing a pullback in the artery and quantifying the amount of athero that exists in that segment of the artery. And it was done at baseline and then at 18 months later. And so they showed that lowering LDL cholesterol with evolocumab reduced the amount of plaque in the coronary arteries, just like statins did as well. So all that was very reassuring and very consistent. But they also did an analysis that is akin to the analysis I showed you in Fourier, looking at the relationship between on-treatment LDL cholesterol and the change in coronary plaque volume. And what you can see is if an individual's LDL cholesterol was between 70 to 90, kind of 1.8 to 2.4 millimoles per liter, some individuals, the plaque grew a bit, sort of above the zero line there in the sort of red area. Some individuals, it decreased, but on average, it stayed about the same. As you got north of 90 milligrams per deciliter, the plaque was growing in those individuals. Conversely, as you go to the left, the further you got below 70 milligrams per deciliter, the more the plaque regressed. And so I think this graph beautifully illustrates what we should use as a guiding principle for treating our patients. If we have a patient and we know that they don't have any atherosclerosis, and that actually can be tough to know. You can't just tell based on symptoms. They could certainly have subclinical athero. But let's say you did imaging, and I'm not an imager. I'm not necessarily advocating that. But let's say you did imaging, and you knew they had no appreciable coronary athero. Then I think you would want to keep their LDL cholesterol under 70 milligrams per deciliter, under 1.8 millimoles per liter. You don't want the cholesterol to be a risk factor for plaque growth. So if you're under 70 milligrams per deciliter, on average, then the plaque shouldn't grow. And again, you want to control their hypertension and make sure they're not smoking, their diabetes, all the other risk factors. But in general, I would keep their LDL cholesterol under 70 milligrams per deciliter. The patients I see as a cardiologist, unfortunately, their arteries have been bathing in too high levels of cholesterol for too long, and they already have a ton of plaque. And so in those individuals, I want to regress as much of the plaque as possible. And so I drive them as far to the left as possible and target an LDL cholesterol under 40 milligrams per deciliter, under about a millimole per liter. Now, I've focused a lot on LDL cholesterol. Here's a graphic that just reminds us that LDL cholesterol is sort of a surrogate for the LDL particles. It's the cholesterol that, by and large, we think is on the LDL particles. But there, of course, are other lipoprotein classes. And so we tend to ignore the triglyceride-rich lipoproteins, VLDL in particular, sort of the dominant one. And this here just reminds us that the metabolism now of these triglyceride-rich lipoproteins has been worked out. Several proteins are critical for that. Lipoprotein lipase is critical for metabolizing these triglyceride-rich lipoproteins, which are also atherogenic. And there are a variety of proteins that serve as a brake for that metabolism, including angiopoietin-like 3 and ApoC3. And so now there are a variety of drugs that are targeting these key proteins. So evolocumab is a monoclonal antibody against angiopoietin-like 3. Used really for patients with homozygous FH as a replacement for apheresis for them. And then vupanorsen is an antisense oligonucleotide developed to block the synthesis of angiopoietin-like 3. And then for ApoC3, then there are two antisense oligonucleotides which have been developed. Brian Bergmark in our group just at ACC just yesterday presented the results for vupanorsen. Powerful reduction in angiopoietin-like 3 levels up to 95%, moderate reductions in triglyceride levels in the sort of 50% or so. And as we'd expect, because it's really focusing on the triglyceride-rich lipoproteins, really modest effects on LDL cholesterol, and also modest effects on ApoB, sort of as a metric for clearance of particles. That's for vupanorsen, which was targeting angiopoietin-like 3. For ApoC3, volanesorsen was developed by Ionis. Impressive reductions in triglycerides, 70%. And now a next generation drug is being developed, and we're working with them, and we're launching phase 2 and phase 3 trials for that. And then I also added on this graph Lp(a), another lipoprotein you're going to hear more about. It is a LDL-like particle, except there is an apolipoprotein little a that's covalently bound to ApoB. And that particle, apolipoprotein little a, sort of has some homology to plasminogen and can be of sort of variable size, but in a variety of epidemiologic studies, clearly been shown to be highly atherogenic, as well as being associated with aortic stenosis. And now there are a variety of drugs being developed, antisense oligonucleotides, small interfering RNAs against Lp(a). These are data for one drug that we're studying, olpasiran. This is a paper that came out earlier this year by Mike Corin and colleagues in the phase 1 trial for it, where you can see with this small interfering RNA against Lp(a), you can drop levels by 95% or so. So very impressive results. Michelle Donahue in our group is leading the phase 2 trial, which is wrapping up, and we look forward then, based on those data, to take that forward in additional trials. The last points I'll make in the last couple minutes then is thinking more from a population health point of view. We carry around this notion that we know there's a relationship between the amount of LDL reduction and the risk reduction. This is from CTTC, where we see for each millimole per liter we reduce LDL cholesterol, there's about a 20% risk reduction. In trials that had more LDL reduction, they had bigger risk reductions. And if you do a meta-regression line, that's where you get the roughly 20% risk reduction per millimole per liter reduction in LDL cholesterol. But these are data from clinical trials. And Brian Ferentz did this very nice graph here, where let me orient you to this. Again, the x-axis is the magnitude of exposure to different LDL cholesterol. Each square here is a study, a clinical trial, an observational study, and the y-axis is the proportional reduction in risk of coronary heart disease. The red data are the same data you saw before for CTTC. Those are the clinical trials, and if you read up on the graph, if there's a millimole per liter reduction in LDL cholesterol, that translates into roughly a 20% or so risk reduction. In gray are prospective cohort studies. There, the risk reduction per millimole, or the lower level, is associated with an even bigger reduction in risk, about a 33% reduction. Maybe there's still some residual confounding, but also the duration is longer. As you see, the duration was about 12 years. And then if you look at Mendelian randomization studies, which are then lifelong lower LDL cholesterol, you see that per millimole per liter lower LDL cholesterol, it isn't a 20% reduction in risk, it's more than a 50% reduction because it's lifelong. And so in work we did with Brian Ferentz, one can model from UK Biobank using genetic risk scores. If individuals had a millimole per liter lower LDL cholesterol and genetically mediated lower systolic blood pressure, what the benefit is. Each of those reduces the odds of developing coronary heart disease by about 50%. You put it together and you get a 78% lower odds of coronary disease, suggesting that if we start early enough in individuals and just lower their LDL cholesterol by a millimole per liter, lower their blood pressure by 10 millimeters of mercury, we could reduce their risk of coronary disease by close to 80%. And the last thing I'll just share with you in a couple of slides here is this notion of lifelong cholesterol burden. This is modeled on a graph that Jay Horton had, I think, initially developed, where the notion here is sort of life years of LDL cholesterol. It's like pack years for smoking. Someone smokes 1 pack a day for 10 years, they have 10 pack years. Someone smokes 2 packs a day for 20 years, they have 40 pack years. Okay? Same idea here. You take someone's LDL cholesterol, if you do the thought experiment that it's constant over their entire life, which it's not, but if you do the thought experiment, you then multiply their age by their LDL cholesterol level, and you get a sense of the total burden. That's the black line for someone with an LDL cholesterol of 120 milligrams per deciliter. As time goes on, that cumulative exposure goes up and up and up in this case, a linear way. The red horizontal line is an arbitrary threshold for coronary heart disease. It's when is someone going to clinically develop coronary heart disease. That will differ based on whether the person also has other risk factors, hypertension, diabetes, smoking, a variety of genetic risk factors. But on average, then maybe in their 60s, they would have manifest coronary disease. Well, we know some individuals are genetically unlucky and they're born with a defect, for example, in the LDL receptor, and they might have one bad gene, and so they have heterozygous familial hypercholesterolemia. Their LDL levels are twice as high, the slope is twice as steep, and they develop their coronary heart disease at about half the age of a typical person. And some people are super unlucky and they have homozygous FH, and their levels are higher still, and they develop coronary heart disease in their teens. But conversely, there are people who are dealt a good genetic hand. In this case, for example, they inherit a loss of function variant in PCSK9, and their LDL cholesterol level is lower, and they are protected from coronary disease. When we think about treating patients, we, based on our guidelines, kind of wait until they're older and they have typically manifest disease or their 10-year risk is high enough. To achieve that in most risk scores, you got to be older, you got to be middle-aged. It's almost impossible to achieve that when you're young. And then we start a statin, and that will shift the curve. It will flatten it out. But we've wasted decades of time in trying to prevent the development of atherosclerosis. And so what happens if we started when people were young adults, right? Then you could really shift the curve. And if one were to do that thought experiment and lower LDL cholesterol by, this is again a thought experiment, an annual injection of something like inclisiran, which probably annually would achieve about a 40% risk reduction. If one were to do that, you would drop LDL cholesterol from an average of 120 to about 70 milligrams per deciliter. And with this pure mathematical thought experiment, you would delay the onset of coronary disease by about 28 years. Now, this is a mathematical thought experiment laid out in PowerPoint. What about the real world? We have a real world example of this. This is, to paraphrase Dickens, a tale of two studies. On the left, MESA, study done in 6 communities in the United States. Industrial society, historically, LDL cholesterol levels of about 120 milligrams per deciliter, or about 3 millimoles per liter. The Chimani Health and Life Project in the Bolivian Amazon, pre-industrial lifestyle, their historically LDL cholesterol levels of around 75 milligrams per deciliter, about 1.8 millimoles per liter. They did CAC, coronary artery calcium scoring, a surrogate for atherosclerosis in these individuals. What did it look like in MESA? You can see that as individuals got older, the median CAC score went up and up and up and up. What about in the Chimani, whose LDL lifelong was 75 milligrams per deciliter? Right? Almost no evidence of coronary atherosclerosis by CAC imaging. Right. So, and what did they estimate? They said there was about a 28-year lag, the exact same difference we estimated just based on that genetic scoring. So let me conclude and look forward to questions. In patients with established atherosclerotic cardiovascular disease, I think you cannot get LDL cholesterol low enough. We know achieving an LDL cholesterol under a millimole per liter is both effective and safe, and we have a variety of excellent drugs to help us do that. In true primary prevention, if they absolutely don't have athero, personally, I want to keep their LDL cholesterol under 1.8 millimoles per liter to prevent the development of athero. And then I think the earlier we lower circulating levels of atherogenic lipoproteins, the bigger the clinical benefit. So we just need to start earlier from a population health point of view. So thank you very much for your attention, and I look forward to the discussion.